Hi, it's Dr. Centeno, and thanks for joining me today. We have an interesting topic today on ear issues and craniocervical instability. So I've had a number of patients through the years with ear problems who have CCI. And this last week had a super interesting patient who came in. When she turned her head, she would get jumping of her ear, pretty reproducible, involving cervical rotation, and then spasm in the facial nerve innervated muscles around the outer ear. So pretty unique. Hadn't seen that one before, but I have seen a lot of patients with ear symptoms. So today we're going to dive into ear symptoms a bit. And then obviously I'll be answering questions. So if you want to ask questions about this topic or any other topic, it's all good. So we will start all of that here. Okay, so hopefully this works. Now, last time we seem to have a problem with the slides advancing. So I may do this a little differently this time. Might do this a little differently. Sorry, guys, just trying to make sure that we can get this done so we don't have the same problem as last time. So let me just quickly save something here. And then we're going to try this a different way today. Okay, so just uploading the slides, trying to avoid what we had happen last time where the slides did not seem to be advancing. So just uploading and it's sort of processing all the different slides. So again, we're going to be talking about ear symptoms and craniocervical instability. Basically had an interesting patient this week when she turned her head, she had jumping in her ear. So she was clearly getting cranial nerve 7 or facial nerve irritation due to her craniocervical instability. Having said that, I've had lots of patients through the years who have ear symptoms. So we're going to get into that today. So let's see. We add that to the stage. Yeah, seems to have worked pretty well. So we'll try it this way this time. So, can ear symptoms be caused by craniocervical instability or CCI? And assuming I advance like that. Okay, so I want you to like, comment, share, subscribe, because that's how you pay it forward to the craniocervical instability community. So do me a favor, if you want other people to be able to see this content, whether you're on Facebook or YouTube, I stream to both. Then please take a minute right now, like, comment, share, subscribe, because that's how they can find this information. There's a new site for direct questions to me personally, and that's RPICL. What I'm trying to do there on Reddit is to create a large index of questions and answers by patients. And then that way patients can go on there and literally just search something to see what I've said in the past about that particular topic. So there's that on Reddit. It's RPICL. And then there's a great place on Facebook for questions and answers among patients. And the reason why I like this particular Facebook group is that it's strictly monitored by patients. They don't really let it get too far crazy and off track. And that's one of the problems that I see with social media sites is sometimes they get kind of off into the weeds, and then you've got a lot of information that doesn't make sense anymore, even common sense, let alone medical sense. So some CCI or craniocervical instability patients report ear symptoms. Sometimes that's burning, spasms, pain in the ear, feeling like there's fluid in the ear. Now, there's lots of things with regard to CCI that can cause that, but I'm going to focus on one mechanism today that kind of ties all these together. So how could CCI and ear symptoms be connected? Let's dive into that a little bit. So I really liked this really pretty diagram here. I've edited it a little bit because the colors didn't work for me. I'm a little bit colorblind, so maybe they would work for you. But you can see here that we've got a portion of the outer ear that's innervated by the lesser occipital nerve, a portion that's innervated by the sensory branch of the facial nerve, a portion that's innervated by the greater auricular nerve, and then the auricular branch of the vagus nerve, and then even auriculotemporal nerve here. What's really interesting about all of that is that there's some commonality here for where these nerves go and how that might be related to craniocervical instability. Because if you irritate a nerve, so let's say I'm irritating a lesser occipital nerve here underneath the sternocleidomastoid, I'm not going to necessarily feel it here, but I will feel it where that nerve goes to, or the back of the head, or to the outer ear, in the case of the lesser occipital nerve. And then we've got the facial nerve, supplies the muscles of the outer ear. So that's the patient I saw, right? This person turned their head and their ear was jumping all over the place due to spasms, and all of these muscles that control the ability of the outer ear to move. So again, this is that patient I discussed before. Patient has rotational C1, C2 instability, turns her head, ear starts jumping, what's going on? And in general, what's going on with ear symptoms in CCI patients. So while there are other mechanisms that can cause ear symptoms other than the one I'm going to be going over today, the one I'm going to go over today I like because it ties all of these together into a nice little package where I think everyone can understand. So you may or may not have seen this before. I've talked about this online, and that is, in this particular case, we have C1, C2 instability, or atlantoaxial instability. People often say, well, AAI is different than CCI. Not necessarily. CCI is the big term. AAI is the specific term that means C1, C2. So we have C1, C2 instability here. Now, since the sternocleidomastoid muscle here is responsible for most of your head movement on your neck, if you're unstable at C1, C2, your sternocleidomastoid is not going to like it. It's going to go into spasm. And then what can that spasm at the sternocleidomastoid muscle cause? So let's dive into that a little bit. So underneath the sternocleidomastoid here, we've got a lot of nerves that come out. These nerves are part of the superficial cervical plexus. Superficial cervical plexus includes the lesser occipital nerve and greater auricular nerve. The lesser occipital nerve, remember, goes to that outside of the ear and then goes to the back of the head. The greater auricular nerve also goes to that outside of the ear. Then there's some other ones down here, but we're going to focus on these two up here that I've highlighted in this diagram. So again, we've got nerves that come out from under the sternocleidomastoid in the back of the sternocleidomastoid, about 2/3 of the way up. They go to the ear, they go to the back of the head. And then we've got the facial nerve, and a portion of the facial nerve, this lower portion of the facial nerve, that interestingly goes right to those same muscles that we were talking about, or cranial nerve 7, also comes out right there. Now remember, there was a sensory branch there that also innervated part of that ear. So we have a portion of the facial nerve coming out in front of the sternocleidomastoid, certainly in a position where it could get pissed off by the sternocleidomastoid, just like the last two nerves we talked about. That sends a sensory branch to the ear, and then there's a motor branch that goes to those muscles that control the ear. And then the vagus nerve runs under the sternocleidomastoid. So this is a cross section here, and you can see the sternocleidomastoid there and the vagus nerve that runs underneath. So we talked about a sensory branch of the vagus nerve that goes to the ear. Now, vagus we've talked about a lot, right? Because vagus does a lot of different things. And the vagus nerve can be responsible for tachycardia symptoms, it can be responsible for POTS-like symptoms, etc. But here we're just focusing on the sensory branch that goes to the ear. And again, as you can see, all four of these nerves we've talked about are relating back to that sternocleidomastoid. And super common for me to see craniocervical instability patients with tightness in their sternocleidomastoid. So all four of these nerves are in a position to be pissed off by a tight sternocleidomastoid. So again, we have tightness in the sternocleidomastoid can drive the symptoms here in the ear, because that's a sensory function, right? You might feel burning, you might feel pain in the ear if these nerves get pissed off. Or if it gets the motor nerves that go to the muscles around the ear, like the patient I saw, and those nerves get pissed off, then your ear starts jumping, in this case, when the patient turned the head. So how can these symptoms be reduced? Well, short term, you might consider an AO or nuclear chiropractor who can realign C1, C2, or just simple myofascial release in the sternocleidomastoid. That could be as complex as seeing an actual myofascial release therapist. That might just be self-massage in the sternocleidomastoid. I've got a patient right now who I haven't yet seen, but I've been communicating with online, who gets great relief with just massaging her SCM, and I've heard that from some patients. Now, realize for other patients, that might be too much. The nerve is so irritated that they can't tolerate anyone messing with that sternocleidomastoid. And then long-term, treat that rotational instability at C1, C2, which is going to be targeting the alar ligaments with that PICL procedure. So short-term and long-term concepts there of how to calm down that sternocleidomastoid. So in summary, the sternocleidomastoid muscle can irritate many of the nerves that go to the ear. The SCM is usually tight due to rotational instability at C1, C2. For short-term relief, upper cervical chiropractic or massage of the SCM may help. For longer-term relief in CCI patients, stabilizing C1, C2 would be the answer, and that's going generally after that alar ligament, which is a direct injection through that PICL approach. So I think that's it. Let me... And then finally, again, like, comment, share, and subscribe if you want to make sure that this information gets out to other CCI patients. So if you want to help other CCI patients and you're just joining us, take a minute to hit that like button wherever you are, whether you're on Facebook or YouTube, so that we can make sure that this content gets out there to other people. Okay, so that seemed to work pretty well. At least I could see that the slides were advancing. So maybe that's the way I'll do it from here on out. Natasha, when performing the laser CCI exercises, should your eyes follow laser or stay in center and use peripheral to move back? Yeah, so really try to keep the laser in the middle. So your eyes are following the laser dot during those exercises. Natasha, can CCI cause the feeling of in your body, ears, the elevator dropping feeling when you're upright? Just to reinterpret that, I think what you're saying is, can you get a sensation that you're dropping due to craniocervical instability? And you certainly could. Now, that could be inner ear vestibular, so you have to get that checked out by a board-certified ENT or ear, nose, and throat doctor. But it's certainly possible that bad proprioceptive or position sense information from the upper neck could cause that as well. Doctor, you've mentioned a lot about Scroth PT of mild mid-thoracic scoliosis that you've seen. Do you have any strong opinions about using heel lift? Yeah, AT, I think I answered that on the Reddit PICL, so I'd go there. But the scoliosis I saw was relatively mild. And so I don't think a heel lift would be needed for that particular scoliosis. Now, I don't know if that's with correction. Maybe it gets worse without correction. So you might want to do X-rays, standing scoliosis series with and without correction and see how that moves. Obviously, if correction reduces it, then I'd stick with the correction. Good morning, Lisa Marie. GM, Dr. C, which supplements do you suggest post-PICL? Really the focus should be, in my opinion, if you've got high systemic inflammation, and that's not everybody, but certainly a high percentage of the patients we see do, then you want to be on anti-inflammatory supplements, things like fish oil, curcumin, etc. And the curcumin part can be with that Regenix stem cell support formula. And then you want to be on other types of supplements that can help joints. So that's usually glucosamine, MSM, chondroitin, those sorts of things. So those are the types of supplements I would usually recommend. Ezra, ear symptoms, geniculate neuralgia, aka intermediate neuralgia, were my most disabling symptoms for my suspected CCI. Can you help shed light on how I think I've gone through that in pretty good detail here, Ezra. So that question was probably asked before I got started. Sure, Rachel. Submitted advance by Sherry. If we have new ear symptoms, how do we know whether to come to you or an ENT doctor? Well, obviously, if they're ear symptoms, you want to get checked out probably by your family doctor first, who can look in your ear and see if there's anything obvious. And then if there's not something obvious and it seems to be connected to your neck, meaning my ear symptoms are worse when I do X with my neck, then we can certainly take a look at it as connected, likely connected to your CCI. If it doesn't appear to be connected to anything in the neck, meaning you can't make it worse by messing with your neck, can't make it better by wearing a cervical collar, then you probably do want to get checked out by an ear, nose, and throat doctor. HRS, doctor, why does culturing stem cells give you a finite number of cells? If we're talking about culturing mesenchymal stem cells are your body's repair cells, and they've got a limit to how much they can grow. So, but they're still stem cells, right? They still sort of leave one cell behind and then replicate themselves. And there's a limit because in adult stem cells, there's a limit. If there wasn't a limit, then your body would continually grow. That's more like an embryonic stem cell. The problem with embryonic stem cells, we've found out through now many, many trials, is they have a tendency to want to form tumors called teratomas. Adult stem cells don't do that. Adult stem cells don't do that because they are designed for repair, not designed to create a whole body. HRS, doctor for regenerating cartilage and knees, you recommend complete bed rest post-stem cell procedure, just regrowth activity is tolerated. I would say more activity is tolerated. Depending on what's going on, you may have offloading of that compartment with a brace for a while. But once the stem cells attach to a lesion, it takes an enzyme to get them off. They don't come off very easily. It's been advanced by Harry Winston. Sorry to be off topic, but do you plan on opening additional Regenix locations in the UK? Any chance of one in Devon? No, probably not. Again, realize, Harry, that Regenix grows when we find a qualified provider. And qualified providers are going to be few and far between. So unlike other things you may see out there where it seems like, so-and-so is advertising on the radio and they got lots of different places, they don't really care, in my opinion, about quality. They're usually using mid-levels who know very little about any of this stuff, meaning non-physicians, or if they're using a physician, that physician doesn't really know much about this kind of stuff. So for Regenexx to grow, it has to find the right doctor, and then we can add that site. So there's a big screening process for the doctor. Then there's additional education the doctor has to go through. So it's very different than opening a McDonald's franchise or whatever franchise is out there in the UK, where there isn't a lot of expertise necessary to open a franchise other than you go through the video that the franchise produces or McDonald's U if it's a McDonald's, etc. HRS, doctor, has your son undergone further treatment with NeoCD lesion after Regenexx C? Yeah, no, he is not. Let's see. My son at the time, if I recall, I want to say he was 13 or 14, something like that. And I knew we had a problem because he was walking down the stairs like an old man, kind of like I walk down the stairs sometimes, not like a kid. So he is about 10 years out now, maybe a little longer, and has not had any problems in those knees. So knock on wood. It's good to be young, but he has done quite well. Rochelle, my daughter's 9 years old. Can age be considered for PICL? Yeah, Rochelle, we generally don't treat patients with PICL who are not skeletally mature. So what that means is that we would have to have evidence that your daughter has reached skeletal maturity, meaning that she's done growing, before we would consider doing a PICL procedure. HRS, doctor, do you prefer red marrow, yellow marrow for stem cells for orthopedic issues? I think what you're referring to is the cellular component of bone marrow versus the adipose component of bone marrow. We use stem cells from both sources. Most places would use stem cells just from the cellular component of bone marrow. HRS, after BMA, I've read that red marrow converts to yellow marrow in that region. That's not true at all. We don't see that at all. So I think what you're talking about is at the local site of bone marrow aspiration, there may be something that changes there. In fact, it's super interesting. Felipe Hernigal, who is the only guy on earth who started doing stem cells before I did. He's in Paris, France, a professor at the University of Paris. Felipe has joined the Regenexx scientific team. We just met with him 2 days ago. And we have some data that shows that there is no change in stem cell content at the bone marrow aspiration site. Felipe also has data. So we're going to put that data together, I think, and publish it as a publication between our scientific team and his scientific team, basically showing that as long as you allow enough time and the right patient, there is no problem with the bone marrow aspiration site. It doesn't drop in stem cell content over time as long as you let it recover. HRS, is there a limit to the number of times? Yeah, so I think that's the same concept. So the answer is no. If you're a young male, based on the data that we have and Felipe's data, Felipe Hernigal's data, really talking about 2 or 3 months before you go back to the same site, there does not appear to be any decrease in stem cell content or cellular content. Now, as you get older, that may take longer to recover. Now we're on the 3 to 4 to 5 month range. But that's quite a bit older. Or if you're a postmenopausal female, then it may take even longer to recover that site, in which case we usually change up the bone marrow aspiration technique in that case. Angela, is one of the symptoms increased ringing? No, so that's a different one, Angela. That's going to be tinnitus. So tinnitus is what doctors say when they mean ringing. And there's all different kinds of tinnitus. There's constant tinnitus, there's pulsatile tinnitus, etc. But that's different than what we're talking about today. Today we're talking about pain, burning, in the ear, feeling like the ear is full, or spasm in the external ear muscles. HRS, doctor would be willing to do a study where previous patients were offered arthroscopy to check access tissues that have been healed using regenerative procedures. It's called a second look arthroscopy study. It's pretty darn hard to get through IRB these days, meaning Institutional Review Board. The reason is obvious, right? You can do it in animals. So there's been a bunch of that work done in animal models where they go in and do a second look arthroscopy. Horse models, for example. But in human models, it's pretty hard to get approved by an IRB because we have really good MRI technology. So usually the Institutional Review Board comes back and says you're exposing the patient to unnecessary risk here of an arthroscopy when you could get a 3 Tesla MRI with all sorts of cartilage sequences and actually get more data about that area than you would through a second look arthroscopy. So that would be a hard one for a human study to get through an Institutional Review Board. HRS, doctor, what's your opinion on chondrofiller for cartilage regeneration? Chondrofiller, that sounds like a non-US one. Let's see what chondrofiller comes up as. Yep, it's non-US. Chondrofiller, I'm just looking at it here. In fact, let me show you what I'm looking at so you can see what I'm seeing. Chondrofiller, so it's a scaffold. Basically, it's a collagen scaffold. Yeah, so it's a collagen scaffold. You know, scaffolds are good. They're not magic. So you'd want to add something into the scaffold, usually platelet-rich plasma or bone marrow concentrate or something, or culture-expanded chondrocytes, etc. But a scaffold is a scaffold. There's nothing magic about a scaffold. It helps healing in that area. Blood is the body's best and original scaffold. Same thing with a bone marrow clot. That's another good scaffold. The scaffold is literally just something that other cells can grow through, and it provides some structure while they're growing through there. So let me get out of that one. Erza, in your clinical experience, what percentage of CCI patients have ear problems? It's not a huge number. I would say that we get ear symptoms maybe reported in about 1 out of 10 to 2 out of 10 patients, but there's enough of them out there for it to be part of the discussion and for me to want to do a video on it. Realize that I use these videos as well, right? Patients use them, but I use them too. If you've ever communicated with me on a specific topic, if I've already done a deep dive video on that topic, I'll send you a link to watch the video because it allows me to have a library of deep dive information where patients can get educated if they ask that specific question. And I've got some sense usually of what I've done in the past, so I can just, fire off, hey, take a look at this video, because I can do it so much more justice in this format than I could just answering in 3 or 4 lines on an email or an online forum. Oh, thank you, Christian. I appreciate that because, listen, it takes a lot of time to do this, right? It takes time to keep up with the Reddit page. It takes time to do these videos. It takes time to do all the little MRI videos. And those are kind of fun for me, to be honest with you, those MRI videos. Those are a lot of fun. And it takes time to answer about 100 patient emails a week, and then obviously see patients as well. So I appreciate you recognizing that takes a lot of time. And it's not something you see from the average doctor out there doing this kind of stuff. There's a reason, because it takes a lot of time. And it takes time away from other things. So thank you for saying that. HRS, doctor, why are intra-articular loose bodies a contraindication in a stem cell procedure? So you know that stem cells require tissue and a blood vessel to attach to. Yeah, I think the biggest concern there is that you got to put intra-articular loose bodies in a joint into 2 categories, right? One category would be they're not doing much, meaning if they weren't there, nothing would change. And so sometimes you'll see small little loose bodies that are sequestered maybe in a joint recess and are probably not causing anyone any problems. But then there are bigger loose bodies that are causing inflammation and mechanically irritating tissues. And those, the second type, should be removed prior to any kind of stem cell procedure. Now, thankfully, the second kind are relatively rare, meaning we don't see them often, but they happen. Some advance by John. Hi, doctor. Any correlation between tight and tender clavicles and CCI? Yeah, John, let's go back for a second, because that's probably a good one, because it's something I look at all the time. So let's see if I can show you this here from what we had, right? So we had this here, and you see the sternocleidomastoid. And so the sternocleidomastoid attaches up here to the skull at the mastoid process. But look where the other side of the sternocleidomastoid is. It's right sitting there on those clavicles. So we often see patients, and I treat them all the time, where they've got instability at the sternoclavicular joint, and they've got a tight SCM. And out here at the acromioclavicular joint, it's also loose. So maybe sometime in the past, they injured that sternoclavicular joint and it's loose, and the ligaments got damaged, or the AC joint and the ligaments got damaged. So I tighten down a lot of SC ligaments and AC ligaments, because that's the base of support. That clavicle and those joints serve as the base of support for the SCM. So if the SCM is pulling against that and it's moving the clavicle, that's not a good thing. That's also going to make that SCM not happy. So we talked today then about two different concepts here, right? One is that the C1C2 is causing the SCM to spasm and that instability. The other is, and you bring up an excellent point, is what happens to the other end of that equation, right? The clavicle and the two joints, the AC joint out here and the sternoclavicular joint in there. If those guys are loose and the clavicle is loose, doesn't that also piss off the SCM? And the answer is it does. So I treat that all the time. So let me get out of that one. Then AT, saw your video on laser light therapy. Although laser can't touch alar transverse ligaments, do you think it could help the ligaments with certain instabilities? Yeah, listen, I don't think there's any reason not to try laser other than financial. Do I think we have data showing that laser will tighten down those ligaments? We don't. So that's a guess that laser will tighten down those ligaments. Having said that, if cost is not the driving factor, and for some patients it's not, then by all means, try laser for the more superficial ligaments to see how that helps. But do I think we've got really hard data that shows that laser is going to help any of those ligaments? We don't. Maybe someone will do that study, but we do for injecting into the ligaments. In fact, I published that study a long time ago, 2 decades ago, where we treated with prolotherapy the supraspinous and interspinous ligaments and saw decreases in translation on follow-up cervical flexion extension x-rays. Mr. Nick, have you seen pulsatile tinnitus affected by the SCM? Yeah, not as often affected by the SCM, less often affected by the SCM for pulsatile tinnitus. Rejects been advanced by John. Why aren't people CCI generally not able to work out, or why are they not able to work out? Because that's the nature of instability, right? So instability goes through a couple different phases. Let's move from the upper neck, where it seems to be a little bit harder to understand, and now let's go to the ankle, right? Let's say you injured your ankle ligaments. Now that's going to go through the first phase. The first phase, like I had it way back when, what I remember was my ankle, I would pay for doing certain things. So that payback was if I went for a run, let's say on my unstable ankle, because the ligaments were lax due to an injury, then later that afternoon, I'd be limping around. Didn't really hurt all that much when I was running. Now, that's early stage instability. But what happens with late stage instability? Well, with late stage instability, had I left it that way, I would have started to get ankle arthritis, and or some of the nerves around the ankle would start to get pissed off. Now I'm in a different world. I can't exercise at all because any time I put any weight on that ankle, it pisses off the joint, it pisses off those nerves. So that's how it works here as well. If you're in early stages of craniocervical instability, you kind of pay for it afterwards. If you're in the later stages of craniocervical instability where the joint is swelling, or the upper cervical facet joints are swelling, you're getting nerve irritation, etc. Now that's a different world. In that world, what we're starting to see is you can't do much. In fact, exercise intolerance, I would say, is one of the biggest indicators for early, meaning you pay for it later, and late stage, you pay for it immediately, craniocervical instability, meaning that a lot of neck pain patients can rehab their way out of it. CCI patients generally can't, and they generally hit that wall hard. And so that's one of the things that we see. Concierge Kimberly, my leg was broken, and when the doctors were doing surgery, they said my ligaments and tissues were mushy. What does that mean? Yeah, so what that means, Kimberly, is it's pretty common with fractures for everyone to focus on the bright, shiny object, right? The bright, shiny object is obviously the fracture, so we want to get that treated. These days, that's usually an open reduction internal fixation or IF surgery. But one of the things that rarely gets focused on is in order to fracture the leg, some of the ligaments probably got trashed too. So I think what they're telling you is, hey, you may have some ligament issues here. Let's see how all of this heals. And once it's all healed, if you're still having difficulty, we may need to revisit those ligaments. Now, the best way, if those ligaments aren't completely torn like rubber bands, and it doesn't sound like they were, they would have told you that, then the best way to treat that is going to be through injection afterwards. So that's going to be prolotherapy, PRP injections into those ligaments. Probably not the same doctors that fixed it from a bone standpoint. It'll be a different type of doctor that does that injection. But I think they're trying to tell you, hey, some ligaments got trashed here too. If those don't get better, put those on your radar for things that might need to be done later. AT, if a patient were to try laser light therapy, you think class 4 would be best to try since it's the strongest. Yeah, if you're going to try to treat anything deep, you want a higher class laser. So I think that's fine. Again, realize that laser isn't magic. It's just light. So at the end of the day, if the light doesn't get there, the laser doesn't get there either, no matter how strong your laser is, it's just light. Pia, regarding SI joint instability, radiologist writes more blurring of the SI joints in the MRI. Do you know what that could mean? That's not a real common medical radiologic way to define anything other than there could be movement artifact, meaning that an MRI requires you to stay still because it takes a while, sometimes in the order of 1 to a couple minutes, to get enough information to create an image. So it could be that you were moving around too much. Now, blurring in this context could also mean I'm not seeing a definitive joint here, so I'm questioning whether or not the joint is fused, which can happen. So either one, I'd have to see the full reporting context. It either means you're moving around too much, and they didn't get a good MRI image, or that the radiologist is not seeing a definitive joint line, in which case he's starting to question whether or not the SI joint itself could be fused together. Some advance by John, would you recommend adhesion release doctors for scalings? I don't know what an adhesion release doctor is, but certainly if you've got tightness in your scalings, and that tightness is not being driven by your upper cervical instability, obviously, if it's being driven by your upper cervical instability, you'll get temporary relief by massaging your scalenes, but not permanent relief. But if you've got a primary scalene issue, let's say causing thoracic outlet, and that involves scarring, then myofascial release, Rolfing, there are also a number of different adhesion release techniques in physical therapy where you use little scraping type tools. Those are different ways to try to treat that. Daniel, do you see that there's better outcomes with EPICL versus PICL? Daniel, I think as I mentioned last time or the time before, we're in the process of looking at all that right now. The fellows have the data that they are taking from charts and putting into a spreadsheet, and then we will start to look at all of that. My sense is yes, there probably is, but that's just my sense. So let's see what the data shows. Daniel, how many times do you hit each alar ligament with a needle? 2 to 3. A lot of that just depends on how the flow goes. I think one of the things that's hard for patients to imagine, and one of the reasons why it's a little bit of a chuckle for me, a little bit LOL for me when I hear other doctors trying to do PICL. I mean, this is the most technically challenging procedure I've ever done. And I've done lots and lots of different procedures all over the body. I've been doing interventional spine work for decades. And it's difficult because there are differences from person to person as to where these ligaments live. There are differences from person to person in things like bursal tissue that you might get into, meaning large lubricating sacs that are swollen. There are differences in anatomy between the way the bones line up with the back of the throat. There are differences in people's ability to even tolerate work through the oropharynx while they're on their back. There are differences and differences and differences and differences, etc. If we get into the EPICL position and the tight bundle of the alar, the first time I can see that very easily, and that's what we do. Now, there are times when the flow is suboptimal, and there are algorithmic routines I've developed in order to take it from suboptimal to optimal. And again, those algorithmic routines took 1,000 procedures to develop. So the idea that someone with no training could just stick a needle back there and get close to where they're supposed to be is an LOL for me, because it took 1,000 procedures to get to the point where I could dial this in. So if someone's done 5 of these or 10 of these or even 50 of these, they are doing a very poor job of it. And this is a good example. So the answer is, for me, it's either 1 or 2 steps to get optimal alar flow. My guess is if you didn't know what that was and didn't know what the algorithm was, you'd hunt and peck around in there for a very long time and still probably wouldn't get it. Jacob, I have a disc injury at 4-5, small protrusion and annular tear. Something can be done to improve your clinic. Is there a way to help this kind of injury heal or improve? Yeah, Jacob, disc bulges at C4-5 are part of normal aging. So there is no reason to fix a disc bulge at C4-5. Now, the question would be, is that disc bulge at C4-5 causing you symptoms and inhibiting what you want to do, in which case there are ways to treat a disc bulge at C4-5. Usually it's stabilizing that level through the ligaments and injecting platelet growth factors around the irritated, pissed off nerve at that level. You could also inject the disc itself, but usually that's overkill for getting rid of the symptoms and allowing the patient to function. But small disc bulges at C4-5 are a dime a dozen, meaning if we take 100 people right now who are 50 years old, walking around in the street, who never had a day of neck pain, about half of them will have disc bulges at C4-5. So we're not talking about pathology as much as we're talking about normal aging. The question is that normal aging, like the wrinkles on your face, getting to the point where it's causing symptoms, in which case it needs to be treated. But it doesn't need to be treated if it's there. It's just like a wrinkle on your face. You can certainly treat the wrinkle. It doesn't really change the fact that the wrinkle's there, meaning you can inject some filler into the wrinkle and make it go away, but the wrinkle is still there and it's still going to come back when the filler wears off. Lisa, does low birth weight and poor child nutrition affect stem cell rate? I mean, maybe from a third world standpoint, but not from a first world standpoint, no. Again, I mean, I think we need to be very careful here of there's what I call the functional medicine definitions of these things, which are more, how do we optimize them to take them from 90% to 100% or 80% to 100%? In that world, no, none of it makes a darn bit of difference. And then there's the third world where we're trying to take it from 30% up. And yes, that's a different world, but I'm assuming you don't live in the third world if you're on this podcast, because that's not generally who I deal with, because of the nature of social media, the nature of the internet, the nature of people who can make it into Colorado for treatment, etc. HRS, do you recommend iron or any other specific supplements post-BMA and post-draw, stabilize iron levels and other parameters quickly? No, not necessary. Now, obviously, if someone starts out anemic and they've had a problem with anemia in the past, then they may need iron supplementation. Obviously, that would be on a case-by-case basis, but 99.99 times out of 100. So we don't see any issues like that. All of that bounces back quite nicely. Pia, does testosterone and growth hormone increase stem cell function? Probably not. Growth hormone maybe a little. We've seen, when we tested that way back when, about a 15% difference in stem cell function when we added human growth hormone to the culture. Wasn't really enough for us to want to start adding human growth hormone to the culture because it may have other risks. Testosterone, we did that experiment. It had no effect at all on stem cells whatsoever. And that was actually a clinical study we did. Ezra, and a patient who's almost 15 with severe stenosis, C2-3, retroverted dens, and AICA loops. Can that cause geniculate neuralgia? That would, yeah, I can't. That's diagnosing online. I don't do that. I'm certainly happy to take a look at all the different films, take a look at the patient's history, take a look at all of that information, and try to make some recommendations from there once I've looked at all of the data, including you filling out a 15-page questionnaire. But I can't do that with a short couple of sentences online. That's not ethical. Christian, yes, I bet it takes a lot of time. Shows you actually generally care about your patients, so thank you again. Thanks, Christian, for recognizing that. Sky, if a connective tissue disorder patient sees 15% improvement in symptoms with SI ligament, PRP injections not enough to move forward with the second treatment. Yeah, so often have talked about SI joint ligament treatment and the number of treatments versus what it is you're doing, right? So, for example, in the average female with SI joint instability, and there's going to be some connective tissue laxity patients mixed into that group, we're talking about 6 to 8 prolotherapy ligament injections to get to maximum medical improvement. If we look then at PRP, it halves that. So now we're at 3 to 4 treatments. So 15%, probably pretty reasonable for a PRP treatment. But again, I don't know the skill of the provider, meaning do not assume that provider A is doing the same thing as provider B is doing the same thing as provider C, because that's not the case out there. What provider A is doing is going to be different than what provider B is doing. It's going to be different than what provider C is doing. So don't start with the assumption that what they did was correct or what they did was all that could be done, or even that they put this stuff in the right spot. Also, don't start with the assumption that what you got as PRP was really optimized PRP. What you may have gotten is what was cheapest for the doctor to make, which is not what's best for you. And then to get back to the original conversation, if we go to bone marrow, now we have that again. So we're at 1 to 2 treatments, somewhere in there. So 15% for SI joint instability sounds about right, a little bit low. I would think with PRP, you'd be seeing more like 25 to 30%. Now, if you have really lax connective tissue disorder like hypermobile EDS of certain variants, now maybe that's fine. But again, don't assume that PRP equals PRP. The PRP you're getting in Clinic A could be vastly different from the PRP you're getting in Clinic B. And don't assume that provider A is doing the same thing as provider B at all. You may be getting a suboptimal treatment. Ezra, what do you think the relationship between these type of ear problems are, hypermobility and EDS? Well, outside of EDS associated with CCI, probably not much, based on what I'm talking about here today. Now, having said that, if you've got HEDS, you're more prone to CCI and atlantoaxial instability, hence you're more prone to SEM tightness, hence you're more prone to these ear problems that we're discussing. Lisa, I just purchased a full-length infrared heating pad. How soon after PICL can I use it? You can start right away. Big thing with heating pads to look at after PICL or any real regenerative procedure is going to be, you want to stoke some increased blood flow, but don't do it so much that you prolong that inflammatory response. So for example, let's say you started out at 15 minutes once a day using an infrared heating pad. Feels good. Everything seems to be 5 by 5. It's not making it any worse. Having said that, I've seen people using it 3, 4, 5 times a day, or for using it an hour, twice a day, and they're stoking up too much inflammation, and it's counterproductive. So they start to go the other direction. So just thread that needle, like everything else we talk about in recovery for PICL. Thread that needle between stoking some increased blood supply, which is good, but not stoking so much inflammation that you start to go backwards. Marcia, pulsatile tinnitus in my left ear. In addition, I have an intermittent mechanical sound in my right ear that is activated by turn of the head. These come from 2 different issues. I've confirmed severe CCI, and my ENT has no knowledge of CCI. Is there an ENT subspecialty of this information maybe that knows about CCI? So no ENT subspecialty that knows about CCI, going backwards on answering this question. I do think it sounds like the mechanical sound is different than the pulsatile tinnitus. Pulsatile tinnitus can often come from intermittent compression of the internal jugular vein. There are other types of mechanisms as well. Whereas the mechanical sound in the ear almost sounds like you're hearing crepitus, for instance, from 0, 1 or 1, 2 as you turn and realize, so let's just look at this here, right? So this is my ear, but right underneath my ear is 0, 1, the 0, 1 joint. So that's the joint between this mastoid process here, or the bottom part of the occiput, and the atlas. So if I've got crepitus coming from this area, the closest thing to perceive that is that ear. So it just may be crepitus or cracking and popping from those upper neck joints, because those upper neck joints are in close proximity to the ear. Walter, saw a patient this week with total body tingling with neck movements. Atlas is quite anterior to otherwise normal PLL line, luckily compressed in dorsal columns, also right, only C1, C2 DJD treatment. Well, I'm not sure I can tell you what kind of treatment for that patient. So the big things I would be thinking about with total body tingling and neck movements would be, do we have an MRI? Is there cervical stenosis? If there's not cervical stenosis on the MRI, then is there upper cervical instability on a digital motion x-ray? So that's the next thing I would do, is to rule out instability on a DMX. And then depending on their age, the right C1, C2 degenerative joint disease could be appropriate for age if that person is 70. But if that person is 40, then that's an indication probably of long-term instability at C1, C2, because arthritis in this area in the upper cervical spine increases as we age, but is generally not there in 30-year-olds and 40-year-olds. So that's how I would look at that. Just ordered upright flexion extension MRI. I think that'll be helpful, but realize that an upright flexion extension MRI will show some of the types of instability or craniocervical instability, and a DMX will show other types of craniocervical instability. So just realize that may be a false negative if it doesn't show much. Ezra, so at the beginning you mentioned this is one example of ear problem CCI. Could you comment on a wide variation on how wide the variation could be in CCI? Yeah, so what I was talking about is that let's just take one of those things, right? Facial nerve irritation. The facial nerve also comes out of a specific foramina in the skull. So you could get irritation at that level in the skull, having nothing to do with the sternocleidomastoid. So that's, for example, one of the things I was talking about. James, are there any published papers in infectious PICL procedure outside of what CS has produced? Well, that would be impossible since we're the only people on earth that do the procedure, right? So that's not going to happen at this stage, meaning there'd be no other way for someone else to do a study because no one else knows how to do the procedure at this juncture. As I think I've said on the Reddit thread, and you may want to go there, that we are in the process of our third data analysis, and this one is we will publish, meaning more than publish online, publish in a peer-reviewed journal. So the fellows have that now. They're going through hundreds of MRIs. They're going through hundreds of histories. They're pulling the data out of that so that we can do the final data analysis on that and start to slice and dice things. For instance, by CCI type, slice and dice versus PICL versus EPICL, etc. And then that will be published. But as far as others doing that, that would be impossible, right? No one else knows how to do the procedure, so no one else could do a study on it at this point outside of us. Elias, 4 years in of multiple neck, ear, facial nerve irritation, started with sudden numbness behind head, right side, also electric type, shooting pain, hypersensitivity cycles, can't seem to find help. Yeah, so that could be craniocervical instability. Obviously, you'd want to make sure simple things are crossed off the list, like you have brain MRI and no one's detected any tumors. There's a neck MRI, no one's detected any tumors. But working that up for craniocervical instability would certainly be reasonable. Mr. Nick, could untreated CCI for many years contribute to C2 pannus? There will also be correlating signs of imaging if that's the case. There's no history of arthritis, also like we're doing this. Yeah, so a pannus, presence of a pannus is going to be more common as we age, more common in certain disease states like rheumatoid arthritis, for example. But if you're seeing a pannus in someone without rheumatoid arthritis who's 40 years old, then you start to think that's circumstantial evidence that there could be craniocervical instability. Now you've got to get to better evidence of it. So you've got to do the movement-based imaging, flexion extension, upright MRI, DMX to confirm that. But it's good circumstantial evidence that something's going on. And like many things in medicine, sometimes following the circumstantial evidence gets you to the answer. Stephen, best email I can get a hold of you on. I had a Zoom call with you and forgot to ask an important question about my CCI. Yeah, Stephen, I'll put the email address that goes to my desk in the comments here. So Centeno office at centenoschultz.com. That's the email that goes to my desk. I just put it in the comments. And then we are coming up on the hour here. So I'm just going to take a few more. This is when I kind of start looking at for some interesting ones here. That's an interesting one. Gajaro. Hi, Doc. Can CCI cause upper motor neurons signs? It's possible, I think, because you're getting upper cervical cord irritation sometimes. So in some CCI patients, assuming again that the brain MRI is clear and there's no evidence for why that person would have upper motor neuron signs. So for example, if you've got severe C1, C2 overhang, it's certainly possible that their dura is getting banged into, or if they've got a severe type 1C instability with a retroverted dens, and you're seeing the dens right up against the upper cord there. Yeah, I mean, that would be a reasonable thing to consider, that pressure and intermittent compression of the upper cord could cause upper motor neuron signs. But the first thing that needs to happen, obviously, is other things need to be ruled out. Natasha, DMX, I'm waiting for MRI, which also shows the craniocervical junction and hoping they do rotational images. Just wondering, do you like old MRIs and CTs to review? Yeah, so Natasha, we really don't need an MRI of your craniocervical junction. That's the first thing. What I need is movement-based imaging and not rotation. Rotation, I think, is low yield. So I need upright MRI with flexion and extension and or a digital motion x-ray if it's available. I do not need a rotational MRI because that's very low yield. And I don't need a specific upper cervical structural MRI because that's also low yield. And then I think it's going to be my last question here, guys. There's all sorts of great questions continuing to come in, but I'm coming up against the hour here. Marcia, I had 3 MRIs over 1.5 years that mentioned as an incidental finding bone edema at the sacral ala rheolite insufficiency fracture to this edema-related instability versus a fracture. Yeah, it could be for sure. Here are the things that I would think about. So in a young person, I would think about possibility of SI joint instability versus some sort of inflammatory arthritis that could be causing issues in the SI joint. In an older person with a lot of osteoporosis, I think that the leading number one would be making sure that there's no insufficiency fracture. Instability less common because usually the SI joint fuses as we get older. So those are just my thoughts off the top of my head. Okay, guys, good to see you. I will be here next week, probably with something else interesting. I always love for patients to send me emails about topics they want to hear about. I think someone did this week. I've got to check back in my emails. You have the email address that goes to my desk. It's down there. So look forward to getting one of those emails about some interesting things. But in the meantime, I will be back next week. We will be talking again about another interesting topic. I thank you so much for all the great questions. Again, what this weekly event is all about is trying to learn through questions, whether those are our questions or seeing someone else's question get answered, because in my experience, that's how you get educated patients that know which end is up. And patients that know which end is up tend to do better than patients that have no idea of what's going on. So thanks so much for watching. Have a great day, and I'll see you back next week. Same bat time, same bat channel. Thank you.